The next speaker is Dr. Nilesh Kumar. Efficient surgeries through complex cataract flow.
So, thank you, sir. And I would like to thank AIOS for this opportunity. I'm Dr. Nilesh Kumar, and why I am giving this talk is because we were the first one in the country to have this entire cataract workflow from Zeiss. So these are my financial disclosures. I am a consultant and an R&D from Zeiss. What are the components that constitute a cataract workflow? The first comes is optical biometer, that is IOL master, either 500 or 700, but preferred is 700. And then the data transferred into Callisto Eye, that is the where you see and you record your videos and you do markerless toric system. Those data and those video feed is injected into your microscope, that is Lumira system, Lumira I, Lumira T, or then 700 or 900, and then the Zeiss Quattro 700, and we are humbled that we were the first commercial installation of Zeiss Quattro 700 in, it was a tier 3 city, but we were fortunate enough to acquire that. So I'll talk about all these components in detail here. So why IOL Master 700? I don't think there is any debate in that this is the gold standard for optical biometry. Most widely installed optical biometer give excellent reference images. So what this does is, apart from giving us the optical biometry, it gives us an excellent reference image with sclera very clear. So that scleral image is matched. The limbal vessels are matched in the Callisto via AI, and that is injected into our Lumira eyepiece. So how it is connected to Callisto is completely, there is no scope of human error. It is directly connected via Forum. Forum is an DICOM-based intercommunication between all the Zeiss machines. So what it does is, once we take an IOL master, optical biometry through IOL master, it injects the data into Callisto through that forum. So completely eliminating use of dependency on any optometrist, as well as reducing any human error. So there might be a human error when they are manually feeding the data. Here it is not going to happen. And then the reference image from the IOL master is matched through the Callisto Eye on the patient. Apart from that, Callisto Eye also is a digital markerless toric system. So you don't need to worry about your toric placements. It also gives you LRI, it also gives you OCC placements. So complete astigmatism solution is through Callisto Eye. And also what it usually does is it records all of your surgeries. So in last 1 year, I have 5 TB of data of my own surgeries. So I just keep going back, any complication that is happening or anything that odd has happened, I just go back and see at the end of the day. That I think optics of Zeiss is world class. There's no doubt about that. Anybody who has used this has been the gold standard for last 7 years, and we are very happy. Now Callisto injects the data into one of the ocular eyepiece, not on the binocular side. It goes on one side. The only problem is this records, but if you are having an external recorder also, then the external camera should not be placed over EDIS, otherwise there is a lot of glare and a lot of poor quality image in that camera. So if you want to have 2 camera systems, this provides, Callisto Eye provides you up to 1080p of video recording. If you want to have 4K video recording, you have to have another camera on another eyepiece. Now coming to the new talk in the town, that is the Quattro 700. Quattro 700 is based on a new pump system. It's neither Venturi nor peristaltic pump. It is something like 4 injections, 2 injections for irrigation and 2 injections for aspiration. So there are like 4 chambers into that pump. So what happens is, if you have, those chambers are 32 hold 32 ml of BSS. So what happens is when 32 ml of BSS is being pushed from one of the chamber, another chamber is vacant where a negative suction of 32 ml has been created. So in real time, it is matching 1 ml of fluid that is going out and 1 ml of fluid that is coming in. So even if there is a minimal amount of leak, it is immediately compensated at that time. That's how there is an absolute rock solid chamber stability. I am operating I have operated from around 30 millimeter of mercury in high myopes to 60 millimeters of mercury in my routine cases. There is no difference in chamber stability throughout the machine. So this is how it works. You can see one side when it is injecting, the other side it is aspirating. Both are active. It's not a passive infusion or it's not a passive suction. Both are active, and a pressure sensor is there so that it immediately compensates for whatever leak is happening. So apart from that, there is one excellent benefit. There is something called as power on demand. So we all know at the last piece, we have to use our foot pedal to control delivery in third during emulsification. So what happens in power on demand is only when occlusion is happening, there is a delivery of power. Otherwise, just as soon as the occlusion breaks, the power delivery stops. So there is no, even if you are in a foot pedal 3 position, there is no delivery that is going to happen unless there is full occlusion. So there is no chance that a surge will happen and you won't get a PCR. So PCR rate has rarely, it has gone down drastically since I have started using this machine. So how the entire cataract workflow is, it assesses and educates you. You can plan your surgeries via IL biometer and then via the EQ workplace that is there. Then you treat your patient using the host of machine, that is your Callisto, your microscope, and your Quattro machine, and then you go back and imagine and check whatever wrong has happened. You can just go and recorrect yourself so that next time it doesn't happen. So this is how my OT looks. It has been 1 year since we made a modular OT with a vision that we are not going to have any wires hanging around. But thanks to Zeiss, now everything is wired. There are lots of wire hanging around, but I love working in this environment. I spend around 3 hours over daily doing surgeries. And this is my experience in the last 1 year. A single refractive surprise has happened in the last 2,500 cases that I have, since I have started using this cataract suit. Toric accuracy is almost all cases with almost 96% cases I have had a good toric accuracy. Markerless toric system helps a faster OR turnaround time with cataract workflow, and my surgical time has reduced by around 45% with the new Quattro machine. So it's all because of efficient chamber stability that I have less number of phaco rejects now. So thank you for this time.
Thank you very much, but I think many people in this audience won't be able to afford this entire complex, the microscope and the Quattro and the IOL Master, etc. So I think it's an excellent presentation and tells us how to go about it.
So, but we are practicing in a tier 3 city. It was my father's private practice, and we also thought that it is not possible. But I think with the amount of revenue that it starts generating once you have it, I think it's just to take that first step. Once you take that first step, I think, because I joined my father's practice last 1.5 years back. I have exhausted all his saving, but he is very happy that we are now a premium
What
center
machine
in
were
the
you
area.
using earlier for phaco?
So, Signature Pro.
Signature Pro, and you find a vast difference between the two?
Yes, sir.
In the surge control?
Yeah, the chamber stability, like the PC doesn't flutter at all in this, and there is no financial interest. I am not being paid to say this, but the PC is completely stable with Quattro 700.
Yeah, I've used the Quattro, and I've got a video of the side port just leaking fluid straight out.
Because it operates on a flow rate of around 70 to 90. If you lower the flow rate or you lower the IOP, still there is good stability, and they have upgraded it. Last 2 months we got a new hardware upgrade. After that, all those things have drastically come down.
You had a question. We can address it now.
So, sir, I had a question for Shail sir, Anurag sir, as well as Ramamurthy sir. So, I am a very young surgeon in my practice, and usually I am not using Alcon lenses. If there is a patient posted for Alcon, I would do the surgery and probably ask my father to inject it, because Alcon lenses, as I've heard from my father, as well as some senior surgeons, that it's famous for sometimes overshooting. So I had the same problem in inserting Hoya lenses as well. When I was doing a wound-assisted IOL implantation, it was kind of overshooting, or I would end up, implanting the lens outside and then again reimplant it. So my question is, if you just increase the main port and then instead of doing the wound-assisted, if you do go inside the wound and then implant it, wouldn't it be better and avoid PCRs in IOL implantation in Alcon specifically, sir?
I think that's the point that you mentioned is very correct. It's probably not specific to one particular brand of IOL. It is specific to it. There are two, three factors involved. One is the temperature at which the IOL is. So if the IOL is very cold, the hydrophobic IOLs will become very stiff, irrespective of what the brand is. Second is appropriate cartridge and IOL selection. So if the cartridge is too small for that power, that again can cause squeezing of the IOL significantly more. Third is what I showed in my case. If you are not careful, particularly with a shooter injector, if you are not careful enough that the plunger should be at the optic haptic junction and not override on the optic. When it overrides on the optic haptic junction, it gets locked. The IOL gets locked between the cartridge and the plunger, and therefore it doesn't come out well. Fourth, like you correctly said, whenever there is any wound assisted delivery or any form of, even if you're using a screw injector, there is absolutely no shame in having a slightly larger incision. So safety is always paramount importance. So if you find that with 2.2 incision I'm struggling, make a 2.4 or a 2.5. In my case, that like you saw, the cartridge was actually inside, so it was not even a wound assisted, it was just an oversight that the optic was doing that. So I think these 3-4 things, irrespective of the type of IOL, this will occur even with preloaded shooting injectors, because all of these factors put together can cause this. So I think these 3-4 things, if you keep in mind, the IOL, for example, we make sure that particularly in winters, we bring it only before we actually have to open the IOL. If it's there right from the surgery in the cold winters with cold AC, it will become very stiff.
The only thing I also want to add is that there is not much of induced astigmatism even if you go from 2.2 to 2.4. So this concept of that the desire to go for smaller and smaller incisions is no longer there. Earlier we had this thing, then we had bimanual and other things. So now we've come to a conclusion that induced astigmatism does not increase even if you go to a 2.4 or 2.5 millimeter incision. So go inside the wound and inject it gradually. So, and do not try wound assisted. I don't do any wound assisted injections anymore of the lenses.
So I think very important point by sir, safety is first, rest everything else can come.
And especially while injecting into the anterior chamber, once you start the injection, keep watching it, and say some 1/4 or the half of the lens is gone out of the cartridge. You just try to keep drawing the nozzle of the injector. Just keep drawing slightly, because if your nozzle is at the center, it will definitely hit if you last. But if you draw it a bit, it won't hit the posterior capsule at the opposite side.